Hello, my name is Sergey Rumentsov, and I'm attending neonatologist in Massachusetts General Hospital Neonatal Intensive Care Unit and instructor in pediatrics in Harvard Medical School. Today, I'm going to talk about life-threatening condition in the newborn or neonatal emergencies in 50 minutes. I have nothing to disclose for this presentation. World Health Organization describes a newborn infant or neonate as a child under 20 days of age. During this first 28 days of life, the child is at the highest risk of dying. It is thus crucial that appropriate feeding and care are provided during this period, both to improve the child's chances of survival and to lay the foundation for a healthy life. And I think that would be a good introduction to our today's conversation. It is very common to have a presentation about neonatal emergencies, and almost all of these presentations start the same way. There is usually a clinical vignette which describes a 6-day-old full-term infant who presents to local emergency department with a history of poor feeding over the last 24 hours, and now with lethargy and increased work of breathing. At the moment of presentation, this infant is afebrile and with poor perfusion. And the question comes up, what do we do next? What is the differential diagnosis? And as most of the talks describe, we use mnemonic to talk about the condition which called the misfits, which include trauma, heart disease, endocrine disorders, metabolic disorders, inborn error metabolism, sepsis, feeding formula problems, intestinal catastrophes, toxins, and seizures. And although this is a good way to talk about neonatal emergencies, I feel that in today's climate and the way we do our pediatric work, there is a need to build this conversation in a slightly different format. Today, pediatrician is more subspecialized as ever, and the doctors like myself, for example, work exclusively in high acuity setting in neonatal intensive care unit. On the other hand, a lot of pediatricians continue to practice in hospitals, and every day they get asked to do more and more within these hospitals, including overseeing general pediatric floor, providing consultation in the emergency room, participating in the deliveries, and very often rounding in special care nurseries. As a result, it would be fair to look at what are indeed the life-threatening condition in the newborns in the United States. And over the last decade, the United States experienced significant decline in neonatal and infant mortality, with current rates of infant mortality at 6.05 and a rate of neonatal mortality at 4.04. And as we look what the conditions which actually cause the infant mortality, which is up to 1 year of life, you will find that the top 5 conditions include congenital malformation, short gestational low birth weight, SIDS, maternal complications, and unintentional injuries. As we zoom in and separate neonatal and postneonatal mortality, we'll find that the most common condition causing neonatal death in the United States is prematurity and congenital malformation. There are also a substantial portion of neonates affected and dying due to maternal conditions and complications of labor and delivery. And finally, sepsis and diseases of circulatory system continue to be a significant portion of neonatal mortality as well as respiratory distress. As a result, I decided to present my talk in a slightly different format than classically accepted and talk about neonatal complications in the light of preparation for the delivery, immediately in the delivery room, and in newborn nursery and beyond. Hopefully today we will be able to review new and old things you should know and remember. And I would like to start with preparation for the delivery and consulting mothers and preparing yourself. It is not a secret that preterm birth is a major factor in neonatal mortality and probably cause of the most neonatal death in the United States. As we look at the structure of birth in the United States, the vast majority of the patients who are born are actually 37 weeks or more. On the other hand, the patients who make a minority of our deliveries are less than 32 weeks, contribute the most to the neonatal mortality and represent almost 55% of neonatal mortality today. As a result, it's very important to understand when we see a mother prior to delivery and provide a consultation as a pediatrician to this mother about prognosis for the infant, what are the exact numbers and how they change over the last decades. And here's the data analyzed by National Institute of Health working group looking at only U.S. centers, and it looked at outcomes of extremely premature birth in cases where aggressive resuscitation was and was not provided. And as you can see that even when these data pulled together, the survival for the patients at 24 weeks is approximately 55%. Survival without morbidity, on the other hand, remains somewhat low for the group where no resuscitation was included as well. One of the important things to know and use today for prenatal consult is neurodevelopmental outcome calculator. The data for that were published in 2008, and this calculator is widely available from NICHD webpage. It essentially required input of several factors, including gestational age, priority of birth, estimated size of infant, and exposure to antenatal steroids. Based on that, this calculator generates a predictor of survival, death, and morbidity associated with premature birth. It is helpful not only for the physician but for parents as well. As we provide the consultation, we have an opportunity to provide a quite reliable number to the parents. It is not a secret that as we provide consults at borderline viability, the default usually to present the data worse than they are in the reality. It has been shown in multiple studies in the past. As a result, I strongly encourage you to use this calculator and to help you to provide appropriate consult to the parents of extremely premature infant. As you can see that, for example, for 24 weeks of gestation, survival using this calculator reaches almost 67%. It also allows you to look at outcomes in the survivors within this group. And although mortality, for example, at 23 weeks gestation remains very high, out of survivors, the portion of the infants who actually survive with normal outcome or mild impairment reaches up to 40%, which is definitely can convince the parents to pursue resuscitation in the future. As we're preparing ourselves for the delivery, we should remember that being ready for an emergency is the biggest part of the success. And as we look at a regular statistic of need for resuscitation and the delivery, almost 10% of all deliveries required some degree of assistance from medical staff, and up to 1% require extensive resuscitation. It is very important to identify pregnancies and potential complication of future deliveries. The red flags from the perspective of pediatric staff should be presence of non-reassuring fetal status, such as Category 3 fetal tracing, history of acute perinatal events such as an abruption and cord prolapse, and decreased fetal movement. Evidence of fetal disease or serious conditions such as prematurity less than 37 weeks, postdates more than 42 weeks, multiple gestations, presence of meconium, high drops in the fetus, and major congenital anomalies. Labor and delivery condition are important as well. Significant vaginal bleeding, abnormal fetal presentation, prolonged or unusual labor, and concern for shoulder dystocia. It is very important to assess maternal factors of infection, such as chorioamnionitis or maternal fever, prolonged rupture of membrane, and history of sexually transmitted diseases. Co-founding factors for poor outcome include diabetes in mother, Rh immunization, history of hypertension, renal, endocrine, pulmonary, and cardiac disease, as well as alcohol and substance abuse. It is interesting, although a lot of people talk about the mode of delivery as an additional risk factor, it by itself, mode of delivery does not pose an increased risk for fetus. It is the most important to understand that the outcomes of high-risk infants born in a low-level setting differs from the one born in tertiary care referral centers. It is the best studied in premature infants, where it has been shown that for extremely low birth weight babies, birth in community hospitals associated with increase in morbidity and mortality. This is just one of the studies demonstrating that for infants less than 28 weeks, birth in a community setting has been associated with increased mortality, chronic lung disease, infections, and intraventricular hemorrhages. As a result, it is very important to ask yourself if you really want to have these patients deliver in the setting where there is no neonatal intensive care unit. Overall, the statistic across the United States supports that over the last decade, there is a significant improvement in amount of transfers of mothers rather than infants in the situation of high-risk deliveries. As you prepare yourself for high-risk delivery, it is important to accustom yourself to the appropriate equipment. And the appropriate equipment for delivery includes a radiant warmer, blended oxygen source, pulse oximetry, flow inflating bag and face mask, bulb syringe and stethoscope, laryngoscope, and a tracheal tube, UVC insertion kits, syringes, needles, T-connectors, epinephrine, sodium chloride, normal saline, and end-tidal CO2 indicator monitor. At that point, you are ready for the delivery, and an important part of that is to know your neonatal resuscitation program, which is today is a standard care in the delivery room in the United States. It has been changing gradually, and it is important to keep up with current changes in NRP program and make sure that they have been implemented in your institution, period. Overall, goals of resuscitation of newborn include minimizing immediate heat loss, establishing normal respiration and lung expansion, increase arterial PO2, and support adequate cardiac output. Neonatal resuscitation program has been available for several decades in the United States and overall familiar to most of the pediatricians. What I would like to bring to your attention today, the things which are stay the same and which are changed in neonatal resuscitation program. such as in the current neonatal resuscitation program, the algorithm of resuscitation remains the same, which is ABC, airway, breathing, and circulation. It is important to remember that it now differs from other resuscitation programs from the older kids, where the algorithm has been changed to favor chest compression. Remember, when we're dealing with neonates, the major source of their distress in the delivery room is difficulty breathing or inability to effectively breathe. The other component which remains the same is that the main goal of neonatal resuscitation in the delivery room is maintaining adequate temperature in infants, especially premature infants. There is a small exception. I'm going to talk later about resuscitating depressed term or late preterm infant. There were a lot of changes introduced in 2011 in the neonatal resuscitation program, and I know that quite a few hospitals are still working on implementing that. Such changes included the way we assess color, use of pulse oximetry in the delivery room, restrictive use of supplemental oxygen in the delivery room, treatment of meconium-stained fluid in the delivery room with no intubation for infants who are active, and a strict protocol for corrective measures for effective ventilation. There were also minor things added, such as tightened temperature control for extremely premature newborns, therapeutic hypothermia for infants with hypoxic ischemic encephalopathy, approval of alternative respiratory support such as CPAP and LMA, chest compressions, and route of administration for epinephrine. One of the most important things in the new neonatal resuscitation program is ventilation corrective steps, which are clearly spelled out. And it really targets more effective ventilation as a way to treat non-responsive infant. That includes adjusting of the face mask, repositioning of head, suction the mouth and nose, opening mouth in a particular way, gradually increase pressure, and constant evaluation and considering a secure airway. As a new criteria for assessment well-being on the infant during resuscitation, oxygen saturation with pulse oximetry has been added, and it's becoming a standard of care to use pulse oximetry during resuscitation in the delivery room. CPAP has continuous positive airway pressure has been endorsed as an alternative mode of respiratory support, especially for premature infant. It has been also acknowledged that laryngeal mask airway can be a viable alternative to intubation, especially in the setting where staff is not proficient with endotracheal intubation. It has been also paid more attention how we provide chest compression with endorsing two thumb technique. Need for increase in oxygen during CPR, and also highly encouraging providers to obtain secure airway prior to administration chest compression. Epinephrine doses has been revised, and currently venous access route is a preferred route to administration of epinephrine. The doses for endotracheal route has been increased to 0.5 to 1 ml per kilogram, weight 1 to 10,000 epinephrine, and it has been endorsed in the case of inability to obtain a venous access to use intraosseous infusion. we are resuscitating extremely premature infant. Our goal is initial stabilization and transfer. And one of the most important things is to provide adequate temperature regulation and respiratory management. Premature infants are more likely to experience significant hypothermia as a result. Use of radiant warmer incubators and also plastic wraps during resuscitation now is standard of care. Respiratory management became more flexible in the case of extremely premature birth versus standard approach where most of these babies have been intubated in the past. Non-invasive ventilation and continuous positive air pressure is an adequate way to manage stable premature infant. Cardiovascular support, adequate fluid resuscitation, and timely transfer to tertiary care center also in the list of important actions in the case of extremely premature birth in community hospital. As we move out of delivery room into newborn nursery, it would be important to talk about other conditions affecting infants. And one of the most common causes of neonatal death and clearly one of the life-threatening condition in newborn period is respiratory distress. And respiratory distress is a composition of symptoms including tachypnea, nasal flaring, which reflects use of accessory respiratory muscles, intercostal and subcostal retraction because secondary to highly compliant newborn rib cage, an attempt to increase the intrathoracic pressure, expiratory grunting, which is a form to increase and expiratory lung volume, and cyanosis in most of the cases secondary to right to left intra and extrapulmonary shunting. The causes of respiratory distress in the newborn are many. They can be divided in 5 major categories, including parenchymal condition, airway anomalies, mechanical abnormalities, and developmental abnormalities. There are some other causes which are not necessary of respiratory origin. When we talk about parenchymal conditions, this is the most common causes of respiratory distress in newborns, and that includes transient tachypnea of newborns, respiratory distress syndrome, pneumonia, meconium aspiration syndrome, pulmonary edema, and pulmonary hemorrhage. When we're talking about airway anomalies, we're talking about choanal atresia, laryngeal web, laryngotracheal malacia, and bronchomalacia, subglottic stenosis, vocal cord paralysis. Developmental abnormalities include lobar emphysema, pulmonary sequestration, cystic adenomatoid malformation, congenital diaphragmatic hernia, tracheoesophageal fistula, and pulmonary hypoplasia. Mechanical abnormalities include pneumothorax, pneumomediastinum pleural effusion, chylothorax, and rib cage anomalies. And finally, others include cardiac disease, metabolic disorders, neuromuscular disease, infection causes, hemolytic vascular causes. As we talk about respiratory distress, I will touch on the few conditions included in this list, most of them of parenchymal cause. And the most common condition we see is a transient tachypnea of the newborns, also known as retained fetal lung fluids. It's a mild self-limiting disorder affecting affecting full-term or late preterm infant. It usually results from fluid accumulation in bronchovascular spaces and peribronchial lymphatics. As a result, what we see is a compression of small airway and overall decreased lung compliance leading to tachypnea. There is well-established risk factors, including C-section, gestational age, large or small for gestational age infant, history of maternal diabetes and asthma, and male gender. One of the advantages of this disease, although it results in increased admission of these infants to special care nursery and neonatal intensive care unit, it is overall a self-limiting benign condition requiring temporarily supportive treatment. Supportive treatment for these infants includes oxygen supplementation, as well as continuous positive airway pressure if necessary. In most of these patients, this condition resolves within the first 24 hours. Respiratory distress syndrome, or also known as a hyaline membrane disease, is a disorder caused primarily by deficiency of pulmonary surfactant and immature lung. It is a major cause of morbidity and mortality in preterm infants. And this is just a representative X-ray of the infant with a respiratory distress syndrome who is also premature and has been treated in our neonatal intensive care unit. Pathophysiology of respiratory distress syndrome has been studied very well and hasn't changed much over the last decade. It essentially built around lung development and two components of that, in particular, presence and amount of surfactant, as well as stage of development of the lung or lung structures. These two affect surfactant function as well as tissue function, and overall affect severity of respiratory distress. As you can imagine, this pathophysiological tree really points you to prematurity and underdeveloped lung and low surfactant content in premature lung. It is true that when we look at infants born less than 28 weeks of gestation, they almost universally have symptoms of respiratory distress syndrome. On the other hand, they really represent the minority of today's birth, and almost universally are born in the large tertiary care centers where they can receive neonatal intensive care. Why is it important to talk about respiratory distress in the setting of general pediatricians? As of today, actually the vast majority of premature birth happens between 34 and 36 weeks of gestation. Within this group, the risk of clearly falls into the category likely to be cared in the community hospitals and likely by a general pediatrician. Within this group, complications of prematurity are actually quite common, and you will be surprised to see some of these statistics. This is a study out of Kaiser Permanente Group from California, where they looked at pulmonary outcomes of what we call late preterm infants born between 33 and 36 weeks of gestation and compared them to full-term infants. As you can see on the right side that they used full-term infants born between 38 and 40 weeks of gestation as a reference point and look at the increase in risk developing need for assisted mechanical ventilation. As you can see, even at 36 weeks of gestation, the risk is increased almost fivefold. And as you go down the gestational age at 33 weeks of gestation, there is almost 30-fold increase in the risk of need of mechanical ventilation over full-term baby. And almost the same number seen in need for oxygen supplementation in these infants. As you can see, featuring that the majority of infants born prematurely born actually late preterm and likely to be born in the community hospital, the risk of seeing and need to understand how treat respiratory distress in premature infant extends beyond scope of neonatal intensive care unit service. There are two major interventions important to know which affects outcome of infants with respiratory distress syndrome. And one of them is a surfactant replacement therapy in which surfactant administered through the endotracheal tube to this infant. And today there are multiple preparations of surfactant are available, and the benefits and disadvantages one over another beyond the scope of this discussion. The majority of surfactants used today belong to natural surfactant, which derived from either porcine or a bovine lung, and contain surfactant protein, and in most of the cases, lipids as well. The most commonly used in our hand surfactant is Curasurf, and although American Academy of Pediatrics in their recent statement didn't endorse one preparation over another, a European statement like that endorsed Curasurf for the treatment of premature infant. It is interesting that over the last several years, the new forms of synthetic surfactant became available worldwide, and one of them has been approved for use in the United States. The advantage of this preparation includes recombinant form of protein and also carefully measured intralipid ratio. Again, the studies of on advantages of one form or another are not entirely clear, and very often, since all these preparations are quite comparable, the cost and volume needed to be administered ended up a deciding factor for the choice of the medication. The other important intervention for the treatment of respiratory distress syndrome is actually a treatment of mothers expecting preterm birth, such as administration of antenatal corticosteroids. Although benefits of antenatal corticosteroids have been known from mid-70s, they became widely used only in 1990s. Since that time, there are multiple clinical trials addressing benefits of antenatal corticosteroid for premature birth published. This is a Cochrane review which was published in 2006 and looked at the benefit of using antenatal corticosteroid for preterm birth. And as you can see, the benefits are hard to overestimate. There is a significant reduction in respiratory distress syndrome, more than 34%, reduction in neonatal death, 31% reduction in intraventricular hemorrhages by 40%, necrotizing enterocolitis by 50%, rate of infection by 44%, and so on and so forth. It is uncommon to see in the Cochrane review conclusion that there is no need for further trials of a single course of antenatal corticosteroids versus placebo in single-cell pregnancies. If you ask me today what is the most important intervention for a premature infant and specifically in treatment or prevention of respiratory distress syndrome, I will almost certainly say that administration of antenatal corticosteroids to the mother is this intervention. Meconium aspiration syndrome is a common entity in delivery room. Meconium seen in a large amount of deliveries, 3 to 18%, but only a small portion of them actually progress to meconium aspiration syndrome and develop signs of respiratory distress. You see on this slide is another patient treated in our unit with meconium aspiration syndrome, and this is a classic appearing chest X-ray with multiple small fluffy-looking infiltrates. Despite the fact that meconium aspiration syndrome is substantially more rare than respiratory distress syndrome, it accounts for almost 10% of all respiratory failures and represent a very high mortality rate up to 40%. Very often it's associated with persistent pulmonary hypertension, and recent advances in high-frequency oscillation, nitric oxide, and also availability of extracorporeal membrane oxygenation improved outcomes in these infants. The pathophysiology is very complicated and essentially based on the fact that meconium has a direct toxicity on many components of respiratory tract, including inactivating surfactant, causing immediate inflammatory response, constriction of pulmonary vasculature, cause of pulmonary cells apoptosis, and increased risk of infection. The treatment for meconium aspiration syndrome really belongs to advanced care neonatal intensive care unit and includes intubation and mechanical ventilation, very often with the use of high-frequency oscillation, surfactant administration, and in the last statement of American Academy of Pediatrics on treatment of respiratory distress, surfactant was formally endorsed as a way to treat meconium aspiration syndrome. Antibiotics, nitric oxide, support of cardiac function with inotropes, steroids in some cases, and also use of a heart-lung bypass or extracorporeal membrane oxygenation. One of other causes of respiratory distress frequently seen at the time surrounding delivery in the newborn nursery is pulmonary air leak or pneumothorax. This is a typical presentation on the X-ray where you can see trapping of the air between lungs and chest wall. The clinical symptoms usually include chest asymmetry and unilateral decreased breath sounds on the affected site. And the diagnosis is usually established via a chest X-ray, or in case of an emergency, transillumination offer an excellent alternative which can save you time in your decision making. Management is truly driven by clinical symptoms caused by pneumothorax. In most of the cases, these patients either experience no respiratory distress or minimal respiratory distress. In that cases, the appropriate treatment is observation. On the other hand, some of them have oxygen requirement and might need additional oxygen supplementation in the setting of progressing respiratory distress. It would be fair to say that there were some small studies indicating that use of high concentration oxygen improves a resolution of pneumothorax. Unfortunately, the studies are quite small and unconvincing, and due to rising concern among intensive care unit doctors that oxygen poses a separate risk due to toxicity, it would be unusual today to use so-called oxygen or nitrogen washout and providing these patients with 100% oxygen unless required by clinical symptoms. And finally, significant pneumothorax require thoracentesis and in some cases chest tube placement. One of the small remarks I wanted to make about this approach is that in today's world, amount of chest tube placed by regular practitioner is almost non-existent. It is a quite invasive procedure and requires a significant training. As we practice, even in neonatal intensive care unit, the way we ventilate babies today and manage them from respiratory perspective also results in significant decrease of unexpected pneumothoraces. Even people working in neonatal intensive care unit today have less and less experience in placing chest tubes. One of the excellent alternatives is using pigtail catheters, which are easy to use, very similar to thoracentesis, and also easy to be trained on mannequins. As a result, I would encourage everybody who is interested to learn that versus learning how to place a chest tube. Congenital diaphragmatic hernia is, although uncommon condition, is a life-threatening emergency, which also requires somewhat different management in the delivery room and after. It occurs in approximately 1 in 3,000 live births. Although true incidence hard to estimate since this condition is in most of the cases well diagnosed on prenatal ultrasounds, as a result resulting in so-called hidden mortality, where the portion of these pregnancies terminated at the earliest stages. It is interesting that survival of infants who have congenital diaphragmatic hernia across multiple centers remain steady over the last several decades. On the other hand, in high-volume centers, there are reports of significantly increased survival, in some cases approaching up to 90%. It is important to remember that 85% of diaphragmatic defects occur on the left side and 13% on the right side. So left-sided diaphragmatic hernia is more common. Another surgical condition associated with respiratory distress is a tracheoesophageal fistula. And this is just one of the recent patients we had in our unit, and one of the hallmark of this condition, as you can see, is our inability to pass an nasogastric tube into the stomach. As you can see, it terminates right here on the X-ray. What you see on this X-ray is also gasless abdomen, suggesting that there is no connection between trachea and distal esophagus. I think it really simplified the diagnostic of this condition, although this is a least common form of tracheoesophageal fistula with isolated esophageal atresia. The most common form with tracheoesophageal fistula actually present with normal gaseous content in the stomach. It is as common as congenital diaphragmatic hernia, and estimated in 1 per 3,000 live births. It is more commonly associated with chromosomal anomalies and seen more commonly in twins. Although survival of tracheoesophageal fistula is significantly better than the infants with congenital diaphragmatic hernia, the long-term pulmonary complications are quite significant, and a lot of them require long-term pulmonary follow-up. At this point, I stop talking about respiratory distress and concentrate on neurological emergencies. Hypoxic ischemic encephalopathy is a type of encephalopathy secondary to perinatal asphyxia. It presents as a heterogeneous syndrome characterized by symptoms of central nervous system dysfunction in infants born at term or near term, more than 36 weeks of gestation. The frequency of neonatal encephalopathy in the United States is 2 to 3 per 1,000 live births, and this is a condition which is associated with high morbidity and mortality. Why is it important to discuss this condition in the setting of neonatal emergency? Because in 2010, the American Academy of Pediatrics released a special report acknowledging the non-investigational status of therapeutic hypothermia for infants with moderate to severe hypoxic ischemic encephalopathy. As a result, today therapeutic hypothermia is a standard of care. It is very important to understand that because for many years, hypoxic ischemic encephalopathy has been treated symptomatically, meaning we provide necessary support without any hope of improving outcome. Today, we actually have a treatment which provides improvement in outcome, and the data are quite strong. For the sake of time, I'm just going to refer to one of the many meta-analyses published on results of therapeutic hypothermia in hypoxic encephalopathic infants. And the results demonstrate that there is an increase in death or major disability. And what is more important, there is an improvement in neurological function in survivors. As a result, it is critical for everybody to be able to identify these patients and transfer them to tertiary care centers, which can provide therapeutic hypothermia in timely fashion. This is just a red flags for therapeutic hypothermia everybody should know. We're looking for patients more than 36 weeks of gestation, history of acute perinatal events such as non-reassuring fetal heart racing, abruption, cord prolapse, low Apgar score, less than 5 beyond 5 minutes of life, need for prolonged respiratory support, meaning need for mechanical ventilation beyond 10 minutes of life, abnormal cord or infant blood gases with a pH less than 7 and base deficit more than 12, and clinical symptoms of neurologically depressed infant in the delivery room and beyond, such as hypotonia, diminished reflexes, seizures, or in some cases, use of Sarnat scale to assess this infant. Neonatal seizures is another condition worth discussing with neonatal emergencies. Seizures clinically defined as paroxysmal alteration in neurological functions such as behavioral, motor, or autonomic function. Today, it includes clinical phenomena that are also associated with EEG activity and therefore epileptic in nature. Every time we see neonate with seizure, we naturally are very worried about this patient because the seizure by itself indicates the disturbance in the central nervous system and need for emergent intervention and possibility of lifelong impact on this person's development. As neonates, our patient experienced highest risk for developing seizure of their entire lifespan. And overall, it's estimated that neonatal seizures make 3 to 5 per 1,000 infants, live-born infants. As we look at the causes of neonatal seizures, it's important to understand that 28 days, although appears to be short, is a long period of time, and the infants who experience the seizure in the first 10 days of life are likely to be different from the one who experienced the seizure in between 20 and 30 days of life. This is just one of the study looking at all incoming patients with a diagnostic of neonatal seizure to neonatal intensive care unit. And as expected, you can see almost 40% of this patient had neonatal seizures secondary to hypoxic ischemic encephalopathy. On the other hand, the second and the third most common causes of neonatal seizure included stroke and intracranial hemorrhages. Finally, the fourth most common cause of neonatal seizure was unknown etiology. The rest of the patients with neonatal seizures had a single numbers, and that includes cerebral dysgenesis, transient metabolic disturbances such as hypoglycemia and hypocalcemia, infections, and inborn error of metabolism. As we talk about differential diagnosis and workup for neonatal seizures, it's important to understand that common things are more common, meaning that hypoxic ischemic encephalopathy, intracranial hemorrhages, and strokes make the majority of the cases, and they are more common. It is very important also to understand that timing of presentation of neonatal seizures is important, such as hypoxic ischemic encephalopathy almost universally presents with seizure in the first 24 hours of life. On the other hand, it would be unusual for these patients to present later. Patients with stroke and cranial hemorrhages very often present on second or third day of life. And most of the other causes, including metabolic disorders, neonatal abstinence syndrome, infections present later beyond 72 hours of life. Although as you look at the statistic, infections are a rare cause of neonatal seizure, it is important to treat them, as missing one is unacceptable. As we work up patient with a neonatal seizure, it's important to remember that EEG is a standard of care today for all the cases of neonatal seizures. It's not only important in diagnostic it, but also to monitoring how effective our treatment, and very often EEG can be used for prediction of outcome. Imaging is quite important in diagnostic as well. Although there is no consensus about what is the optimal imaging for a patient with neonatal seizures, there is less and less desire to subject newborns to computer tomography. As a result, MRI becomes a default mode of imaging for this patient. CBC with differential and platelets, analysis of CSF, cultures including viral are important, electrolytes including calcium, mag, and phosphorus, blood glucose, toxicology screening on the patient and mother, and finally minimal metabolic workup is warranted to determine if there are any signs of hyperammonemia or lactic acidosis. Despite a lot of progress in many other fields of in treatment of many other conditions in neonatal world, treatment of neonatal seizure remains steady over the last 2 decades, and phenobarbital remains a first-line treatment for neonatal seizure. We continue to use phenytoin as a second-line treatment, and these two medications became a staple of treatment of neonatal seizures. One of the unfortunate things about these two medications is that they are not quite as effective as we would like them to be. So very often we have to resort to the third-line treatment, and in that case, benzodiazepines are adequate alternative. Over the last several years, there was a lot of attention paid to other medication, and particular to levetiracetam or Keppra. There are at least 2 small to medium-sized studies demonstrated effectiveness of Keppra as a single agent and in combination with phenobarbital. As a result, in the clinical practice, we see more and more pediatric neurologists using this medication for treatment, especially of resistant seizures. It's important to mention that there are 2 large NIH-sponsored clinical trials for use of Keppra as a first-line therapy currently in progress. I would like to briefly talk about surgical emergency in neonates. Bilious vomiting is one of concerning findings in any neonate because it can suggest that this infant has intestinal malrotation. One of the difficulty of diagnostic intestinal malrotation is the fact that a lot of these patients actually have quite normal X-ray, which can be reassuring, falsely reassuring for the provider. Intestinal malrotation is essentially an abnormal process of rotating and fixation of the midgut. And it can cause mechanical obstruction of the proximal intestine and also twisting of the intestine with ischemia of part of all midgut. It is a common finding in general population. It is estimated that malrotation is as common as 1 in 500 live births. Luckily, only a portion of this patient present with midgut volvulus and a clinical picture of obstruction. Yet, the vast majority of them who present with that present at birth. On the left side of my screen, you will see an X-ray of the patient who presented with malrotation and what turned out to be midgut volvulus. Unlike many other patients we see which have a normal X-ray, this patient clearly had highly dilated stomach and abnormal looking gas pattern in the form of this corkscrew. In the case of suspected malrotation and midgut volvulus, or in essentially all patients with bilious vomiting, even well appearing, emergent upper GI is mandatory and diagnostic. The concerning findings on upper GI usually include dilated proximal duodenum with abrupt caliber transition in the mid portion of transverse duodenum, and also abnormal positioning of duodenojejunal junction, which appears more inferior and anterior in location than expected. It is critical to recognize malrotation and midgut volvulus because it has dramatic consequences for our patient. Although today, for the majority of the patients treated for malrotation and midgut volvulus with surgical treatment, mortality is quite low, between 3 and 5%. In the case of delayed treatment, the mortality skyrockets to as high as mid-30%. Emergent surgical correction or LAD procedure is the only option for this patient. Another case of bilious vomiting, which can be seen in the newborn nursery, is secondary to duodenal atresia. It is also quite common surgical emergency affecting 1 in 25 to 5,000 live births, and with a good portion of these cases associated with trisomy 21. The clinical finding usually includes intolerance of feeds, bilious vomiting, or sometimes just simple vomiting. Very often what we see is scaphoid abdomen, secondary to the fact that there is no air below the level of obstruction in duodenum. Unlike in malrotation, surgical treatment for this patient can be delayed in appropriate setting. Very often these patients will need a cardiology consult, genetic consult, and also screening for other anomalies associated with trisomy 21. Duodenostomy is the most common performed procedure for this condition. Necrotizing enterocolitis is an acquired condition of diffuse necrotic injury to the mucosal and submucosal layer of the bowel. Although the distal small gut and proximal colon are mostly commonly involved areas, the entire GI tract can be involved, including stomach and anus. This X-ray on the left side represents several classical findings for necrotizing enterocolitis. What you see is portal air over the liver, and also a clear size of pneumatosis in multiple bowel loops. It is the most serious gastrointestinal disorder that occurs during the neonatal period. And although it is uncommon, 0.3 to 2 cases per 1,000 live births, and occurs mostly in premature infants, the mortality is quite high. The mortality in premature infants can reach up to 50%. And this condition also associated with significant morbidity, length of stay, and significant escalation in the cost of care of this patient. This condition is not only limited to premature infants. Approximately 10% of the infants with necrotizing enterocolitis develop it as a full term. Luckily to us, outcomes in full-term infants is better than in premature infants. Another cause of non-bilious vomiting and feeding intolerance in infants is in perforated anus. It is uncommon condition. We see it 1 per 5,000 of live birth. And it's important to understand that it's not usually diagnosed prenatally. And although for most of the patients it's supposed to be diagnosed at the first physical exam, that's very often not the case, and this can be patients seen later. This is an X-ray of one of these patients who was admitted to our service at several days of life due to feeding intolerance and abdominal distension. And upon further careful examination, was discovered to have an perforated anus. Congenital heart disease is a common cause of neonatal emergencies. It's the most common category of congenital structural malformation, and it's usually divided in non-cyanotic with left to right shunting and cyanotic from right to left shunting. As you look at the most common congenital heart disease condition, you will find that the top 3 is actually fairly benign and rarely cause of significant neonatal distress and include VSDs, ASDs, and PDAs. As a result, although we see congenital heart disease in almost 1% of infants in North America, only a fraction of them actually have a severe critical congenital heart disease, which is estimated for United States as approximately 4,800 patients a year. Most common cyanotic lesions associated with this distress include tetralogy of Fallot, transposition of great arteries, truncus arteriosus, total anomalous venous return, tricuspidal atresia, and in some cases more uncommon edits such as severe pulmonary stenosis and variants of single ventricle. It's important to look at frequently unrecognized congenital heart disease because they are the cases of neonatal emergencies which you're likely to see in the newborn nursery or in the emergency room. Coarctation of aorta, interrupted aortic arch, aortic stenosis, hypoplastic left heart are the most common conditions. When we're thinking about critical congenital heart disease, what we're looking at presentation, which usually includes cyanosis, shock, severe pulmonary edema, very often presence of murmur, and a lot of other non-specific findings which makes it different to diagnose and distinguish from other life-threatening neonatal conditions. Despite all the progress in modern technology, hyperoxia test remains the most useful, and it is also easy to obtain. High PO2 in the arterial blood are usually quite reassuring and in many cases can rule out most of the cases of critical cardiac disease. Echocardiography, ultrasonography, chest X-ray, and BNP level can be also used for diagnostic of a congenital heart disease. The most important component of the treatment of congenital heart disease is actually suspecting it. Because if you're suspecting congenital heart disease in the patient, you are going to go on the right pathway and first and foremost involve pediatric cardiologist. And then follow a lot of other steps which would be appropriate for critically ill patients, such as volume resuscitation, respiratory support, in some cases oxygen supplementation. The second most important step you can do for the patient with presumed congenital heart disease is administer prostaglandin E, because the vast majority of critical congenital heart conditions you're going to see are secondary to their duct-dependent lesions, and maintaining open ductus arteriosus is vital for the treatment of these patients. As a result, administering of prostaglandin, even when in doubt, is quite important for these patients. We hope as we move forward with preventive medicine that amount of patients we see with undiagnosed cardiac disease will reduce. There is a significant effort to establish pulse oximetry screening for congenital heart disease. There is a strong body of data which includes almost above 200,000 newborns, confirming that this approach can pick up significant portion of patients with congenital heart disease with high sensitivity and very high specificity. As of last 5 years, this approach has been encouraged by American Academy of Pediatrics, and most states actually today have laws mandating implementation of this screening. And congenital heart disease screening is likely to detect hypoplastic left heart, pulmonary atresia, tetralogy of Fallot, total anomalous pulmonary return, transposition of great arteries, tricuspidal atresia, and truncus arteriosus. As you compare to the list of undetected conditions, most of these conditions are on this list. Infection is another common source of neonatal distress, and as we talk about neonatal sepsis, we usually separate early onset sepsis and late onset sepsis. Although depending on what literature you read, you will find that the cutoff date is different. The majority of neonatologists use 3 days of life as a cutoff for early onset sepsis. The hallmark of that is a high mortality, is closely associated with maternal history and prematurity. And the most important risk factors for early onset sepsis include low gestational age, prolonged rupture of membrane, presence of maternal fever or chorioamnionitis, GBS status, and appropriate treatment. The frequency of early onset sepsis is estimated to 2 per 1,000 live births with culture-proven sepsis. It is estimated that over 40% more include so-called culture-negative sepsis. And prematurity is a major risk factor for developing early onset sepsis. GBS remains a leading cause of neonatal sepsis, and it causes up to 40% of the cases. The second most common cause is gram-negative organisms, specifically E. coli. It is interesting that over the last several decades, there were no significant changes in the way we actually treat early onset sepsis, and combination of aminoglycoside and extended spectrum penicillin, such as ampicillin, is a mainstream of this treatment. On the other hand, late onset sepsis is usually considered in the cases for more than 3 days. It has significantly low mortality, and in many cases is postnatally acquired. On the other hand, important risk factors also include gestational age, need for respiratory support and treatment in neonatal intensive care unit, presence of central line, congenital anomalies, and GI tract pathology. It is interesting that although gram-positive organisms remain the majority of cases of late onset sepsis, GBS actually make a minority of the cases, with Coagulacus-negative Staphylococcus and Staph aureus making the majority. There is also a significant portion of cases caused by gram-negative organisms such as E. coli and Klebsiella. Viral infection remain also a significant threat to neonatal health, although they are clearly less common than bacterial. HSV remains the most common cause of neonatal viral sepsis and encephalitis, with high mortality and long-term morbidity. As a result, a lot of patients who are at the risk in less than 28 days are treated today prophylactically with acyclovir in the time of presentation. Enterovirus is the second most common cause of viral infection in neonates and common in the community. Fortunately for us, severe cases are extremely rare. And very often these patients present in the first several days of life, and their clinical picture are very much consistent with sepsis and shock. The highlight of their clinical finding include acute liver injury with marked elevated transaminases, jaundice, and coagulopathy. Severe enteroviral sepsis in neonates associated with high mortality, although in survivors, long-term outcomes are quite good. Congenital CEV remains the most common congenital viral infection in neonates, estimating affecting almost up to 40,000 patients a year. Although the classic presentation with hepatosplenomegaly, direct hyperbilirubinemia, and thrombocytopenia today are quite uncommon. Cases of hearing loss associated with CMV and diagnosed late in life definitely on the rise. Finally, endocrine and metabolic emergencies. Hypoglycemia is a common cause of neonatal distress in the first several days of life. It is beyond the scope of this presentation to discuss it in details. It is important to know that in 2011, American Academy of Pediatrics released a statement with a recommendation on the treatment of patients with hypoglycemia. It's targeted towards asymptomatic patients and separates the level of hypoglycemia between birth to 4 hours of life and 4 to 24 hours of age. It essentially comes down to the fact that low glucoses, it's acceptable to tolerate low glucose level between birth to 4 hours, and it is less acceptable after the first 4 hours of life. Other endocrine conditions requiring attention include congenital adrenal hyperplasia. It is difficult to diagnose in some cases because a small portion of male infants have no findings on clinical exam. Hyponatremia, hyperkalemia, and hypertension is a hallmark of congenital adrenal hyperplasia. Hydrocortisone replacement should be administered in addition to regular resuscitation for this patient. Thyrotoxicosis is nowadays rarely seen because of better quality prenatal care offered here in the United States. Delayed presentation in infants born to mother with Graves' disease is common. They usually present with irritability, tachycardia, and hyperthermia. And use of beta blockers, in particular propranolol, is immediate necessary treatment. It is very difficult to talk briefly about workup for a suspected metabolic condition. And when we talk about a patient who is critically ill without any specific cause obvious immediately, we should always think about possible error of metabolism. And the workup should include ABG to assess pH level, lactate and ammonia level, LFTs, serum electrolytes including calcium, mag, and phosphorus, urine-reducing substances, urine ketones, plasma and amino acids, and urine organic acids. And as we gain this data, it will allow us to answer three of the most important questions which allow us to differentiate what condition we're dealing with. The first question, is there metabolic acidosis? Because if there is a metabolic acidosis, it is more likely to be maple syrup urine disease, organic acidurias, fatty acid oxidation disorder, and primary lactic acidemia. If there are hyperammonemia, which points us towards urine cycle defects disorders, propionic acidemia, and metamalonic acidemia. Is there hypoglycemia, which suggests presence of organic aciduria, fatty acid oxidation, and defects of gluconeogenesis? One of the most important things in diagnostic of error of metabolism is actually knowing your newborn screening program. There is currently a recommended uniform screening panel in the U.S., which includes 31 metabolic and endocrine conditions. It is very likely that local newborn screening is either include all these conditions or actually exceeds that. For example, in Massachusetts, where I practice, there are 31 mandatory and 23 byproduct testing plus optional screening. And if you look at the list, you will find that majority of life-threatening metabolic and endocrine conditions are tested for, including congenital adrenal hyperplasia, maple syrup urine disease, acidemias, oxidation defects, and etc. When metabolic condition is suspected, please contact local newborn screening program because they probably have an answer for you. In summary, of my talk, I just wanted to remind you that calculator for outcomes in extremely low birth weight infants is available and very useful. Adequate preparation for the delivery is important. Neonatal resuscitation program had some significant changes over the last decade, and it's important to know them. Therapeutic hypothermia today is a standard of care, and you should consider referring patients with suspected hypoxic encephalopathy to tertiary care center. American Academy of Pediatrics now has a statement on hypoglycemia, and it is important to follow it. Screening for congenital heart disease is here today and likely to help us to diagnose some of the cases of late presentation of drug-dependent lesions. And finally, diagnosis of inborn error metabolism can be challenging, but newborn screening